Good morning, guys. Can you hear me okay? All right. Welcome back. Happy Thursday. So, folks, let's finish up chapter 5. So we're going to be done with chapter 5 today. And that also means that the quiz for chapter 5 is going to open today. In fact, it is open already, okay? And as usual, you have it until Sunday night, 11 p.m. to take the quiz. Do not forget to take those quizzes. I do not reopen the quizzes, especially because you guys have several days to take them. Don't leave it for last minute to take the quizzes, okay? So let me share my screen with you. All right. And now we are done with the discussion of physiology for the skeletal system for the bones. We are going to get into naming of the bones. And then we're going to finish this chapter talking about the different types of joints. Okay. Now, we're going to start at the skull. We're going to go over the axial skeleton first. And then when we're done with the axial skeleton, then we're going to move on and discuss about the appendicular skeleton. And we know that the skull is divided into what we call the cranial bones, and we have the facial bones. The first bone that I want to take a look here right now is what we call the frontal bone. And this bone is one big plate of bone right on our forehead. It is a single piece of bone, so you don't need to worry about right and left, okay? Because again, it's a single plate of bone. Moving more posteriorly, now we're going to get to what we call the parietal bones. And we have two of those. We have the right parietal and we have the left parietal. All the way at the base of the skull, we're going to find the occipital bone, which is also a single plate of bone. And then to the side of the skull, where our ears are, we're going to find what is called the temporal bone. And the temporal bone has some important bone markings that I like to ask questions about it in the exam. One of those markings, folks, it is a bridge between the temporal bone and another bone that is called the zygomatic bone, right here, which what we call our cheekbone. This is called the zygomatic. And this bridge that is connecting the temporal with the zygomatic is what we call the zygomatic process of the temporal bone. Okay, so this entire section here, which again literally is a little connection, a little bridge between the temporal and the zygomatic, is called the zygomatic process. Now, I mentioned this in the lab, and I know that maybe not all of you, but many of you are also taking my lab this semester, in which every time that we talk about a bone marking, we also need to describe what is the bone which the marking belongs to. Okay, because a bone marking doesn't exist on its own. A bone marking belongs to a specific bone. And I need to have that entire information in order for the question to be correct. Okay, because you need to be descriptive. So if I was pointing to this bone marking right here on an exam, you would simply say zygomatic process, right temporal. So you gave me the name of the marking and you gave me the name of the bone, and the bone is the right temporal. Okay, there are some other markings here also on the temporal bone. There is this channel right here, which is called the meatus. This is called the external acoustic meatus. So this would be the external acoustic meatus, right temporal. And then we have another one right here called the styloid process. So this would be the styloid process, right temporal. Moving on with some other bones here of the skull, we have the sphenoid, which we're going to have a better look at it with the skull removed and we're going to be able to see the sphenoid a lot better, which is a single plate of bone. And it does have an important bone marking that I'm going to talk about in a second. Looking inside the orbital space, we're going to find the ethmoid. In front of it, we're going to find the lacrimal. And then all the way at the top of our nose, shown there in blue, we're going to find what we call the nasal bone, which is actually bilateral. There's a little line that separates the right from the left nasal bone. Holding up our upper teeth, we're going to find the maxilla, and the maxilla is also bilateral, just like the zygomatic bone is bilateral. Now, talking about the zygomatic once again, don't confuse the zygomatic bone with the zygomatic process of the temporal. Two different things. One is a bone on its own, the zygomatic bone. The other one is a marking of the temporal. Okay? And finally, holding our lower teeth, we have the strongest bone in our face, in the skull, and that is what we call the mandible. So don't confuse mandible with maxilla, right? This slide right here basically just describes to you what bones of the skull are bilateral. If you have a two in front of it, that means that we have it on the right and on the left side. While the ones that are single plate, you're going to find the number one in front of them, okay? Just to facilitate your life here a little bit, in case you are in doubt if a bone is bilateral or not. All right, some other inner structures of the skull, folks. And here we have a superior veil of the skull with the top of the skull removed. And another bone marking that I want to focus on right here is this big hole on the occipital bone. This hole is what we call the foramen magnum. Remember, foramen is an oval or round hole through a bone. So, and magnum means large. So this is a large oval hole on the base of the skull, which is going to allow the cord, our spinal cord, to pass right through it, which is an extension of the brain, okay? Then we have this foramen here on the temporal, which is what we call the jugular foramen, in which the jugular blood vessel is going to run right through it, feeding blood into our neck and our head region. We have a big marking, very important marking on the sphenoid bone, and that's what we call the sella turcica. And the sella turcica is literally what we call the Turkish chair, because it is a little chair on the sphenoid bone in which the pituitary gland is going to sit inside. The pituitary gland is such an important gland, is what we call the master endocrine gland. We're going to talk more about it when we talk about the endocrine system. But the pituitary gland is so important that it has its own little space, its own little protection inside the cranium. Now, looking at an inferior veil of the skull with the mandible removed, we're going to be able to see the shoe flat surfaces right here, which are to the side of the foramen magnum. These flat surfaces, folks, they will articulate with the first vertebra, which is what we call the C1. Okay? And our head, our skull is literally sitting on top of the C1, the first cervical vertebra. And the articulation that happens is between the C1 and what we call the occipital condyle of the occipital bone. So these are markings of the occipital bone. And we have one on the left-hand side. So we have the left occipital condyle of the occipital bone. And we have one on the right-hand side, which is the right occipital condyle of the occipital bone. Looking at inside our oral cavity, the roof of our oral cavity, folks, we're going to find the maxilla. And we can see right here, the maxilla is split into two. There's a clear line right there in the middle. And the maxilla forms most of the roof of our mouth. And there is a marking on the maxilla, which are some grooves right here. And we call this the palatine process of the maxilla. And once again, we have they are bilateral, right? We have the palatine process of the left maxilla, and we have the palatine process of the right maxilla. Also making part of the roof of the mouth, more towards the back of the oral cavity, we're going to find another plate of bone that is called the palatine bone. So don't confuse palatine bone with the palatine process of the maxilla. Similar situation with the zygomatic bone and the zygomatic process of the temporal. Okay? Any questions, folks? All right, and now taking a closer look at the anterior view of the skull. And I want to show you here inside the nasal cavity, we have this bone right here. And that is what we call the vomer, which literally makes the floor of our nasal cavity, okay? And a little bit of the wall. So the floor and a little bit of the wall of the nasal cavity is formed by the vomer. To the side of the vomer, still inside the nasal cavity, we're going to find what we call the inferior nasal conchae, which are bilateral. We have them on the left, we have them on the right. And as I mentioned before, the strongest bone in the face is the mandible. And there is an important marking right here, which is a little foramen. That's what we call the mental foramen. And we have the right mental foramen of the mandible and the left mental foramen of the mandible. Okay. And then we have the antisocial bone of the skull, and it's called the antisocial because it does not articulate with any other bone of the skull. It is held in place by long ligaments, so they don't physically touch with any other bone. And this is what we call the hyoid bone. Now, some unique features of the skull. The skull, folks, the plate of bones in the skull, in the cranium, they actually have little sutures. They have little separation once we are an adult. When we are still an infant, all the way up to around 18 months of age, all the way up to 2 years of age sometimes, the cranium plates are separated from one another. They are not fused together like what we have as an adult. And what separates the plate of bones in the cranium is a soft tissue, almost like a cartilage, that we call the fontanelles. So the fontanelles, also called the soft spots, are this separation in between the cranial bones. And what is the purpose of this? The purpose of the fontanelles are actually double. One of them is to allow that big-headed baby to pass through the birth canal. As the baby is passing through the birth canal, that fontanelle and the skull will deform. I don't know if you guys ever seen a newborn baby that was delivered through vaginal delivery, and oftentimes they have a little cone head. Okay, that goes away, but the cone head is because there is no fusion of the cranium bones yet, allowing for the cranium to deform. Another purpose of the fontanelles is because as a young baby, a young child, the brain is growing much faster than the bone itself. And that allows for the accommodation of the brain as the brain grows. Another unique feature of the skull is that we have a bone marking called the sinuses or the paranasal sinuses, which are cavities within the skull that are filled with air and covered by mucous membrane. Now, what happens when you have a sinus infection, folks? What happens is that the tissue of the sinus, the mucous membrane, becomes inflamed. They start to produce fluid, and the fluid will fill up that cavity. And when they fill up, they're going to put pressure right there. So this is what we call a sinus infection. To memorize the individual name of the vertebra, with the exception of two. The very first two vertebrae, we're going to talk more about them. I want you to be able to know the name of those two, which is going to be the C1 and the C2, okay? Now, we know that the vertebral column is divided into different curvatures or different sections. The first 7 vertebrae is what we call the cervical, and it goes from C1 all the way to C7. Then we have the thoracic vertebra or the thoracic curvature that goes from T1 all the way to T12. And then we have the lumbar vertebra, and the lumbar vertebra goes from L1 all the way through L5. Okay, a total of 5 of them. Below that, now we get into the sacrum or sacrum, which is actually vertebra that fuse together. During the process of evolution, they lost the little invertebral disc that they used to have. So now they are all one piece of vertebra. And then all the way at the end of the sacrum, we're going to find the coccyx, which is also made of fused vertebra. What does a typical vertebra looks like? This here is a typical vertebra. And let's take a closer look at some of the anatomy, some of the structures that we find in a typical vertebra, okay? Now, just to orient yourself, this is a superior view, guys, from the top, okay? This section right here is anterior. So this is the front. And then we have the back, posterior. Now we can see right here, this is where the invertebral disc is going to be found. This is what we call the body of the vertebra. Then we have the spinous process of the vertebra, and we can feel the spinous process. If you take your fingers and you run down on your vertebra, you can feel all those bumps, right? You are feeling the spinous process of the vertebra. To the side of the spinous process, we're going to find what we call the transverse process, which are connected to one another by what we call the lamina. So the lamina is a little bridge between the spinous and the transverse process. In the middle, we have another large foramen, and that's what we call the vertebral foramen, which again, the spinal cord is going to run right through it. Down here, we can see what is called the pedicle, and the pedicle is connecting the transverse process with the body. And then we have flat surfaces that will serve as point of articulation with the ribs and with other vertebrae as well. One of those flat surfaces is what we call the superior articulate process and facet. And you can see here that is lighter in coloration, and that is because it has articular cartilage covering the surface. Down here, we can see the superior costal facet, which again is also covered in articular cartilage. And then we have the transverse costal facet, also covered in articular cartilage. Now, again, what is going to articulate with these facets, folks? The ribs and another vertebra. This superior articulate process and facet right here, guys. This is what allows one, imagine my finger here is one vertebra, okay? And these 2 fingers here are the superior articulate process and facet. They're going to come in and they're going to touch, they're going to lock in place by articulating within those facets. Now, this is what that articulation would look like with the vertebra and a rib. You can see right here, literally touching each other at the superior costal facet and touching each other right there, the transverse costal facet. All right, now, as I said earlier, there are 2 vertebrae that I want you guys to know by name. And those are the very first two, the C1 and the C2. And we're going to see what's special about them, okay? The C1, guys, is also what we call the atlas. Why is it called the atlas? It is called the atlas according to the Greek mythology, in which we have the god, the Atlas god that is holding the world on its shoulder. Okay? Now, the atlas here of the C1, what's happening, what it's doing is that it is holding our skull. Remember that we have that occipital condyle of the occipital bone, which are the flat surfaces. They will articulate right here with the atlas. It's going to sit right on top of the atlas, in which we can see right there, there is articular cartilage covering that surface. And the atlas allow us to nod our head. So when we do the yes movement with our head, moving up and down, is due to that articulation between the atlas and the occipital condyle. The other important vertebra is the C2, and the C2 is also what we call the axis. And the C2, the axis, has a very special feature called the dens of axis. What is this den of axis? Everybody look up here, please. Imagine my finger here is the den of axis of the C2, okay? What's going to happen is that the C1 will literally fit inside the den of axis, and that allow us to move our head from side to side. So the no movement that we do with our head is due to that articulation of the C1 with the den of axis of the C2. Okay? All right, folks, everybody look up here, please. I will absolutely, positively ask you a question about this in our next exam. I don't know how much more explicit I need to be to make that clear. And then I wonder, in the next exam, as I'm grading the exam, I'm still going to see a bunch of you getting this question incorrect. And that makes no sense, because I am telling you it will be on the exam. I'm going to be using the same figure that you are looking at here right now on the screen. And what I want you to answer on the exam, I'm going to ask you, I'm giving you the question here, folks. I'm going to ask you, give me 3 differences among the different vertebrae. Only 3. There are several differences right here. You can pick 3 of them. So let's go over some of those differences, okay? One of the differences among the cervical, thoracic, and lumbar vertebra is that the cervical is the smallest of them all. The thoracic is larger than the cervical, and the lumbar is larger than all of them, than both of them. That's one difference. And I know 99.9% of you is going to pick this one difference because it's the low-hanging fruit. And that's okay. It is a valid difference. Another difference would be in the foramina. And remember, what is a foramina? Foramina is the plural of foramen, which is a oval hole. The cervical has 3 foramina. It has 1 vertebral, and it has 2 transverse right here. We can see that the thoracic and the lumbar, they only have a 1 foramen, just the vertebral, 1 vertebral, 1 vertebral. That's another difference. Let's look at the spinous process. And this is the spinous process right here, right? We can see that the spinous process of the cervical is often, not all of them, with the exception of C1 and C7, but most of them, they are bifid or bifid. What does that mean? It means that they split at the end. just like what we're seeing right here in the PowerPoint slide. What about the spinous process of the thoracic? It is long and thick, while the spinous process of the lumbar is short and blunt. Let's do a couple of more differences right here. Let's look at the transverse process. Okay, we can see that the transverse process of the cervical is small, while the transverse process of the thoracic is fairly large, while the transverse process of the lumbar is large and blunt. Let's take a look at the articular facet for the ribs. Guys, I have a question for you. What curvature of the vertebral column do we have attachment of ribs? Again, the question is, what curvature of the vertebral column we have ribs attached to them?
Thoracic?
Thoracic, absolutely. We don't find ribs at the neck. We don't find ribs at the lower back. We don't find them in the C curvature, in the L curvature. We only find them in the thoracic. So take a look here. We have articular facets in the thoracic vertebrae. They are absent in the cervical and the lumbar. Okay, there was 5 of them that I want to go over with you. You only need to know 3. Is this clear, folks? Any questions? All right, moving on. Let's talk about the pelvis now. Actually, this slide here is misplaced. Sorry, I'm going to get back to this slide here. I don't know why. Give me a second here. Okay. All right, folks. I don't know what this is there. Why? All right, so moving on. Now let's take a look at the sacrum and the coccyx, okay? Which again is all the way at the end of the vertebral column. And as I mentioned before, both the sacrum and the coccyx, they're actually made of fused little vertebrae. And there is some parts of the sacrum and the coccyx that I do want you guys to know, some markings of those bones. One of the markings that I do want you guys to know, it is a marking that we call the ala. And ala literally means wings. So this is the wing of the sacrum, okay? Then we have the sacrum canal, and the sacrum canal is going to allow the cauda equina, which is part of the spinal cord, and those nerves are going to run right down into the sacrum. And then we have a little piece of cartilage that is called the sacral hiatus. Now we can see there are many foramina on the sacrum, and this foramina is what we call the posterior sacral foramina. Why do we have them, guys? We have them so that nerves can pass right through those holes, right through this foramina. Now, since we're talking about the spinal cord, let's talk about some spinal cord problems or issue with the vertebral column and the spinal cord. Folks, throughout our life, during our lifetime, we're going to have two different spinal curvatures. When we are a fetus inside the womb of our mother, and soon after we are born, we have what is called a C-shaped spinal curvature. Why would we have a C-shaped spinal curvature? The shape of the curvature here, folks, allow for the little fetus to be able to fit inside the womb of the mother. So we know that babies are all curled up inside the womb of the mother. Now, when this baby is born, that C curvature will stay for a while. And this is the reason, if you ever wonder why a human baby does not come out of the womb walking like many other animals do, is because we don't have the appropriate curvature at that moment to allow us to be able to walk. So what's going to happen then is slowly the baby is going to start moving around on the floor, and then slowly is going to start crawling, and then slowly is going to start standing up, and eventually this baby is going to start walking, because now it is enough time for the spinal curvature to change from the C shape into the S-shaped spinal curvature, okay? Which is what we call the secondary curvature of the vertebral column. Now, I have a question for you folks. Why do you think we have a S-shaped spinal curvature? Why isn't the spinal curvature a straight line?
Balance?
Okay, so it's more than balance, but you're in the right track, Stephanie. More than balance. Look at the shape, folks. What does it look like to you? Guys, when we are on Earth, do we have any force being applied to us right on top of our head?
Gravity.
Gravity. Gravity. Okay, and having this S-shaped curvature allow us for better distribution of the force and the weight of our body. It is a much better structure than if we had a straight line. Imagine a spring. Okay, and the spring is all curved, right? So that allows for better weight distribution. This is why we have an S-shaped spinal curvature. Now, what are some of the abnormal spine curvatures? And all of these conditions here, they are genetic. Let me make that clear. I often get that question. Often I get this question, Professor, my kid carries very heavy backpack to school. I know. My son also, you should have a huge backpack, bigger than him. Does that is going to cause scoliosis? The answer is no. Okay, because all of these abnormal spinal curvatures here, they do have a very strong genetic component to them. Now, the most common of the three different types of abnormal spinal curvature is scoliosis. And scoliosis is a sideways curvature of the spine, as we can see right here in this picture of this individual, a very, very accentuated scoliosis. Guys, most kids, as they are growing up, they have a certain degree of scoliosis. If you go and you take your child, your kid, to the pediatrician, they're going to look at the back and say, yeah, there's a little bit of a scoliosis here. Most of the time, the majority of the time, that scoliosis goes away as they grow older. Sometimes, however, the scoliosis do accentuate, it becomes larger. And this here, folks, is going to require that individual to wear a back brace. Now, the brace is only effective if that individual is still growing. Because if you put a brace on an adult after he's already stopped growing, the brace is not going to be very effective at reverting the scoliosis. In that situation, that individual is going to need surgery to correct the wrong curvature of the spine. Another type of spinal abnormality is what we call kyphosis. And kyphosis is an exaggerated rounding of the back. Remember the hunchback of Notre Dame? That's what it would look like. And then there is lordosis, which is an accentuated inward arch of the lower back. Okay, so very accentuated here, that inwarding in the lower back. Another condition that is related with the spinal cord and the vertebral column is something called the spina bifida. And spina bifida it happens because of an unfused vertebral column. And there are three levels of severity of spina bifida. We have what we call the spina bifida occulta, and this is the most mild one. There is an opening of the vertebral column, but of the vertebrae, but that opening is not too wide, so it doesn't allow any spinal cord or spinal fluid, CSF, to pass through it. Then you have another type of spina bifida called the meningocele, in which the opening is a little larger, and that's going to allow the CSF, cerebrospinal fluid, to seep through. And then you have the most severe one, in which we can see this little baby right here has it. And this is what is called the myelomeningocele, in which the opening is large enough to allow both CSF and the spinal cord to seep right through it. Now, you might be wondering to yourself, what does this vertebral column, unfused vertebral column, looks like? Everybody look down here. Folks, here we are looking at the C1. How do I know this is the C1? Well, I can see the dens of axis here of the C2. And if you look down here, the little arrow, you can see that the vertebra did not fuse completely when the baby was being formed inside of the womb of the mother. Now, one of the strongest risk factors for spina bifida is deficiency in a vitamin called folate. Does anybody know another name for folate? Another name for folate is vitamin B9, okay? And the folate, folks, is extremely important, especially during pregnancy. And this is why if you wanted to get pregnant, or if you are planning to get pregnant, or if you even are pregnant, your doctor is going to come to you and say you should start taking a prenatal vitamin. Among the different vitamins within the prenatal is going to be folate. Okay? Because if you there's a lot of epidemiological studies that have shown that mothers that have a low intake of folate during pregnancy leads to an increased development or increased risk factor for the baby being born with spina bifida. Right? Any questions, guys? All right, another very, very common condition of the vertebral column is what we call a herniated disc or a slip disc. Can anybody tell me what region, what curvature of the vertebral column is the most common for the development of a herniated disc? Any guesses? will be
Is
the
it the
cervical.
lumbar region?
It is absolutely in the lumbar region. And the reason why is because most of the weight of the body and whatever is that you are carrying is going to be loaded on our lumbar region. Okay, and this is why this is usually where herniated discs happen. Now, what is exactly a herniated disc? In a herniated disc, folks, what's going to happen is that the intervertebral disc, which is the disc that is separating the vertebrae, they will bulge out of the vertebral column space. And as the little disc bulges out of the space, they are going to apply pressure on nerves that are running right next to it. And a herniated disc pain can be very, very bad. It can be debilitating, guys. Sometimes that herniated disc can be ameliorated or it can get better simply by stretching, like yoga or any kind of stretching helps, in which you're going to elongate the vertebral column. Now, if the slip disc is too severe, and if the disc is damaged beyond repair, now that individual might need a surgical removal of the disc and to implant an artificial disc right there, as we can see it. Okay. All right, guys, moving on to the thoracic cage now. And the thoracic cage is made of two different bones. We have the ribs and we have the sternum. Not all ribs are created the same, folks. We have what we call the true ribs, we have the false ribs, and we have the floating ribs. What is the difference among the true, the false, and the floating? Look, first of all, our ribs are numbered 1 all the way through 12, okay? And those ribs, they are not all the same. The first few ribs right here, let's count them from 1, 2, 3, 4, 5, 6, 7. They are called the true ribs. And the reason for that is because they are directly attached to the sternum. As we can see right here, there's a little piece of cartilage called the costal cartilage, which will attach the rib to the sternum. The false ribs, these ones are not attached directly to the sternum. For example, ribs number 8, number 9, number 10, and then we have 11 and 12. We can see that 8, 9, and 10, they are connected to the sternum, but indirectly through rib number 7 right here. While the last two ribs, which is 11 and 12, they are not connected at all to the sternum. And therefore, we call them floating. Not only they are false, but they are also floating, okay? Because they just float in the air. Now, what about the sternum? Guys, the sternum is divided into different sections. It has different bone markings. And this is something that I love asking questions in the exam. One of the markings of the sternum is a divot right here at the top of the sternum, and we can actually see it, and we can actually put our finger. Right here where I'm pointing my finger, guys, this is what we call the jugular notch of the sternum. This is the marking of the sternum. Then we have the manubrium of the sternum, which is another marking of the sternum. We have the body of the sternum, and then we have what is called the xiphoid process of the sternum. All of these are markings of the sternum. Okay, which means that you need to give me the name of the marking and the bone to which the marking belongs to. All right, so we are done with the axial skeleton. Let's move on to the appendicular skeleton. And within the appendicular skeleton, we're going to have the pectoral girdle. aka the shoulder girdle. We're going to find the pelvic girdle, aka the hip girdle, and we have the upper and the lower limbs. Let's start with the pectoral girdle. The pectoral girdle is made of two different bones. We have the clavicle and we have the scapula. Okay, let's take a closer look at the clavicle and see some markings of the clavicle that I want you guys to know. And then we're going to take a look at the scapula and some of the important markings of the scapula. For the clavicle, we're going to find a blunt end, also called the sternal end, and we're going to find what is called the acromial end, also called the flat end. What is the difference of the two, folks? Look at the name of these markings. The sternal end means that that end is going to articulate with our sternum, right here in the middle of the chest. While the acromial end is the end of the clavicle that will articulate with what we call the acromion process of the scapula, which we are going to take a look next. So these are all markings of the sternum, okay? Let's take a look at the scapula now. And again, the scapula has three markings that I want you guys to know. The scapula has the acromion, and the acromion is what is going to articulate with the acromial end of the sternum. So this is the acromion of the scapula. We have the coracoid process of the scapula, and we have what is called the glenoid cavity of the scapula. Everybody take a look up here, please. If you look at the glenoid cavity, guys, you can see that it's covered in articular cartilage. Why? Because the glenoid cavity will articulate with the head of the humerus. To form what, folks? To form our shoulder joints. Okay? Both the glenoid cavity and the head of the humerus, they are covered in articular cartilage. Now let's take a look at the upper limb. And within the upper limb, we are going to find several bones. We're going to take a look at the humerus, which make up the upper arm. We're going to take a look at the ulna and the radius that makes up the forearm. And then we're going to take a look at the carpals, the metacarpals, and the phalanges, which makes up our wrist and our hands. Now, let's see the humerus first. The humerus has several markings that I want you guys to know. One of the markings of the humerus is this rounded surface right here, guys, in the proximal end of the humerus. And this round surface is covered in articular cartilage. Why? Because it's going to articulate with the glenoid cavity of the scapula. Now, what do we call this round section? This is what we call the head of the humerus right here. Every time that we have a head of a bone, we're also going to have a neck of that bone. And the humerus is special because it has two necks. It has an anatomical neck and it has a surgical neck. What is the difference between the two? The anatomical neck is the neck that is right under the head. The surgical neck is the region of the humerus in which there is a lot of fractures, hence the name surgical neck. In the proximal end of the humerus, we're going to find two bumps that serves as a point of attachment to ligaments and tendons, and these are what we call the tubercles. So we have a greater tubercle and we have a lesser tubercle. In the middle of the humerus, we're going to find a little corner that also serves as attachment for a tendon that helps to hold our deltoid muscle, and this is what we call the deltoid tuberosity. Now, in the distal end of the humerus, we're going to find the capitulum and the trochlea. both of these are covered in articular cartilage. Why? Because they are going to articulate with the bones of the forearm to form our elbow joint. And then we're going to find the two fossas in the humerus. One that we can see in an anterior veil, the other one we can only see in the posterior veil. The one in the anterior veil is what we call the coronoid fossa. The one in the posterior veil is what we call the olecranon fossa. And they are called coronoid and they are called olecranon because we're going to have bones that will fit inside the fossa when we extend our forearm. So this is an extension that is going to allow the bone to move into the fossa. Okay? Let's take a look at the forearm. And the forearm is made of the radius and the ulna. The radius has a lateral aspect, while the ulna has a medial aspect. In the radius, there's a couple of markings that I want you guys to know. One of them is the head of the radius. The other one is what we call the styloid process of the radius, also called the radial styloid process. And the ulna also has some important markings that I want you guys to know. We're going to find the olecranon. And guys, the olecranon is the tip of our elbow. If you touch your elbow right here, the tip of the elbow, you are touching the olecranon of the ulna. Okay? As we extend our forearm, that olecranon kind of disappear. And they disappear inside the olecranon fossa of the humerus. Then we have the coronoid process of the ulna, which is another marking of the ulna. And in the distal end, we're going to find the styloid process of the ulna. Now, let's put all of these bones together and let's understand here how they articulate with one another. Let's take a look at our elbow joint. Everybody look up here, please. So we can see right there the capitulum of the humerus covered in articular cartilage. And we can see that the capitulum is going to articulate with the head of the radius. Then we have the olecranon fossa of the humerus, which is the fossa on the posterior aspect of the humerus. And that is going to articulate with the olecranon of the ulna, which again is the tip of our elbow. Okay. We also have the coronoid process of the ulna, which when we bend our arm, folks, is going to articulate, is going to enter inside the coronoid fossa of the humerus. And that allows us to have that range of motion. Okay. Taking a look at the hands now, and the hands again are made of the carpals, the metacarpals, and the phalanges. And you might have heard of a condition called carpal tunnel syndrome. What is carpal tunnel syndrome? Carpal tunnel syndrome is when we have inflammation of nerves that runs right through our wrist. And this is often due when people they use the type a lot on the computer. They all the time typing, and that can lead to inflammation of the nerve, and that inflammation can compress the nerve and can cause severe pain right there on the wrist. Now, we have several carpal bones, folks, and you can see those carpal bones right here at the bottom. You folks do not need to know individual name of the carpal bones. I know that I listed them right here, but again, you don't need to worry about them. You don't need to memorize them for the exam. What about the metacarpals? Yes, the metacarpal you do need, but the metacarpals is very easy. The metacarpal, they are numbered, right? And they start with the number 1 which is going to end at the thumb. So this is the metacarpal here. So this is number 1, number 2, 3, 4, and 5. The metacarpals are the bones of the palm of the hand, guys, not the phalanges, but the palm of the hand. And then we have the phalanges, and the phalanges are also numbered 1 through 5, with the number 1 being the thumb. So it's 1, 2, 3, 4, 5. But for the phalanges, slightly more complex because the phalanges are divided into smaller bones. We have the proximal, middle, and the distal for the phalanges number 2 all the way through 5. And for the thumb, we only have proximal and distal. There is no middle phalange for the thumb, okay? So how do we name them, folks? Does anybody want to, the folks that are in the lab, anybody want to take a guess? Let's look at this one right here, okay? Number 5 here. Can you name this bone?
Number 5, metacarpal.
Metacarpal.
Sorry.
This bone right here. You guys see it? Right here.
Number 5, distal phalange.
Almost something missing.
Of the right hand.
Of the right hand. Or you can say right number 5 distal phalanx. Or phalange is fine too. Let's try another one, guys. You guys don't look confident on this. How about this one right here? Anybody jump in? Getting you guys to participate is like pulling teeth. Why does it need to be so hard? Oh, I don't want to be wrong. Oh,
Right, number 2, middle phalanx.
absolutely. So this would be the right number 2 middle phalanx. Okay, thank you. All right, guys, moving on. Let's talk about the pelvic girdle now, aka the hip girdle. And the pelvic girdle is made of 2 bones, the hip bones. Okay, and we're going to see that those hip bones, they are fused with actually 3 bones fused together, but we don't need to worry too much about that. The markings that we're going to look at for the hip bones, they belong to the entire hip bone. They don't belong just to one of the fused bones. Okay, so let's take a closer look at them. Now, the hip bones have several different names. The hip bones can be called the pelvic bones, which can be called the coxal bones, which can be called the ossa coxae. For the sake of easiness, simply call them hip bones. So this entire bone that you're looking at right here on the screen right now, this is a hip bone. Now, as I said earlier, hip bones consist of 3 bones fused together. During the process of evolution, those bones fuse with one another, just like our sacral bones fused for the vertebral column, just like the bones of the coccyx fused during the process of evolution. What are the 3 bones that makes up the hip bone? We have the ilium, we have the ischium.
Sorry to interrupt, but it's on the next animation. It's not on the bigger one. Sorry. So it's hard to see.
Oh, again, happening again. Hold on a second. Hold on, guys. How about now? Good. So as I was mentioning, we have three bones that fuse together to form the hip bones. There is the ilium, there is the ischium, and we have the pubis. Now let's take a closer look at some of the markings of the hip bone that I want you guys to know, okay? First of all, what are we looking at right here? Is this the right or the left? This is the right hip. So this is a lateral view of the right hip. And one of the markings I want you guys to know is this surface, this curved surface on the hip that we call the acetabulum. And the acetabulum is covered in articular cartilage, okay? Just like the glenoid cavity of the scapula. Why are we going to have articular cartilage covering the acetabulum? Well, that is because the acetabulum will articulate with the head of the femur, forming our hip joints. Another marking I want you guys to know of the hip is what we call the obturator foramen. And this obturator foramen is a large oval hole, a large foramen in which the obturator nerve is going to pass right through it. And then the third marking I want you guys to know is what we call the greater sciatic notch. And in the greater sciatic notch, we're going to find that the sciatic nerve is going to run right next to it. Remember, these are all markings of the hip. Okay? So when we are naming the bone marking, we need to say acetabulum, right hip. Greater sciatic notch, right hip. Obturator foramen, right hip. Now, as we talk about the hip bones and the pelvic girdle, the hip girdle in general, there is what we call the false pelvis versus the true pelvis. And this is something that I do like to ask questions in the exam. The false pelvis, guys, it is the bony surface of the pelvis itself. So this entire region that I highlighted there for you, this is what we call the false pelvis. The true pelvis is actually the whole. So the space itself is what we call the true pelvis. All right. That being said, let's take a look at some differences between the male and the female pelvis. Folks, everybody look up here. I will ask you a question about this in our next exam. And just like what I said about the different vertebra, I'm going to use the same figure that I have right here. And you need to know three differences between the male and the female pelvis. I can't say this any more clear. This will be on the exam. And we can see there are several differences right here. You can pick only three of them. One of the difference between the male and the female pelvis is the general structure of the bone. The female is usually lighter and thinner than the male, which is heavier and thicker. Why? Because males in general are usually bigger. Okay. Next, we have the false pelvis. Remember, the false pelvis is the bony surface. We can see that the false pelvis of the female is shallow. What does that mean by shallow? Everybody look up here. Imagine that my hands is the false pelvis, okay? This, when it's open, it means shallow. When it's closer in, it means deep. All right, so we have shallow and we have deep. Female is more shallow, while male false pelvis is deeper. Let's take a look at the pelvic brim. And the pelvic brim, also called the inlet, is the line that forms the true pelvis, which is the space here in the middle. If you take a look at the pelvic brim of a female pelvis, they are wide and they are more oval. Now, guys, take a look at the pelvic inlet, the pelvic brim of a male. The pelvic brim of a male is more narrow, and because males in general are usually more romantic than females, it is heart-shaped. Just kidding. That's not true. But it is heart-shaped. Okay? Another difference between the male and the female pelvis, the acetabulum, which is right here, that surface that we articulate with the femur. The acetabulum of female pelvis is small and they face more anteriorly. They face more to the front. While the acetabulum of a male pelvis is larger and they are more laterally. They face more laterally. Let's take a look at the obturator foramen. For a female, the obturator foramen is more oval, while the obturator foramen of a male pelvis is more roundish. And finally, we have the pubic arch, and the pubic arch is the angle at the bottom of the pelvis right here. So the pubic arch of a female is greater than 90 degrees, the angle, while the pubic arch of male is less than 90 degrees. Okay, once again, you need to pick 3 of those differences. And guys, I have a warning for you for the exam. When you are naming those differences, make sure you tell me what you're comparing. Don't go in and just say, oh, female, light, thin, shallow, wide, oval, small, faces anteriorly, oval, greater than 90 degrees. No, tell me general structure. Female, light and thin, heavy, male, heavy and thick. False pelvis, female, shallow, male, deep. Pelvic brim, female, wide and more oval, male, narrow and heart-shaped. Okay? Give me that, what you're comparing among the 2 pelvis. Any questions, guys? All right. Moving on, let's talk about the lower limb now. And the lower limb is made by the femur, the fibula, and the tibia. Let's start taking a look at the femur and some important markings of the femur. Just like the humerus, the femur also has a head. Okay, and that head, it is covered in articular cartilage, as we can see right here, articulating with the acetabulum of the hip. Every time that we have a neck, a head of a bone, and we're also going to have a neck, and the neck of the femur is right there, right underneath it, where the line is crossing. What is the line representing? Folks, when someone say that they broke their hip, and we can see that often, especially in the older folks that have osteoporosis that can then fall down in the bathroom, and break their hip. Most of the time, the fracture is not in the hip bone itself. Even though we call it a broken hip, the fracture actually happens at the neck of the femur. Okay, that is the most common region in which an elderly that falls down, and that's where they're going to fracture, the neck of the femur. Taking a look at the femur here, there are 2 bumps that serve as attachment for tendons and ligaments, and these are what we call the trochanters. So we have the greater trochanter and the lesser trochanter. And then in the distal end of the femur, we're going to find the 2 condyles. We find the lateral condyle, which has a lateral aspect, and we're going to find the medial condyle, which has a medial aspect. And finally, we can see the patella, and the patella is a little sesamoid-shaped bone that is going to help to protect our knee joints. Okay. All right, let's take a look at the lower leg. And in the lower leg, again, we find the tibia and the fibula. Everybody look up here for a second, please. I want you to notice how at the knee joint, only the tibia will articulate with the femur. There is no articulation with the fibula. So the fibula is not really part of the knee joint because, again, they don't touch. Only the femur and the tibia articulates. Okay. All right, let's take a look now at the tibia and the fibula and take a look at some of the markings that I want you guys to know. In the tibia, we're going to find also a lateral and a medial condyle, just like we have for the femur. So now you understand why when we talk about a bone marking, we need also to say what bone the marking belongs to. Because we have a medial condyle of the femur and there is a medial condyle of the tibia. Just by saying medial condyle is not descriptive enough. Okay? So the same way we have a lateral condyle of the femur, we also have a lateral condyle of the tibia. And both the medial and the lateral condyle of the femur and the tibia, they are the point of articulation at the knee. They help to form the knee joints. Taking a look now at still at the tibia, right below the condyles, and we can actually feel this. If you put your hand right below your patella in front of your knee, you're going to see these two big bumps right there. You are touching what is called the tibial tuberosity. And the tibial tuberosity is a point of attachment for the patellar ligament, which is a ligament that is going to hold the patella in place. On the distal end, we have two malleolus. We have a medial malleolus that belongs to the tibia. So it is the medial malleolus of the tibia. And we have the lateral malleolus that belongs to the fibula. And you know these bones right here. If you touch your ankle right now and you feel those two big bones to the side of the ankle, these are the malleolus. You're touching the medial malleolus of the tibia and the lateral malleolus of the fibula. Right. Now, these malleolus, they will articulate with the bone of the foot that we call the talus. And we can see that right here on the screen, guys. And that is going to form our ankle joints. We're going to take a look at the talus. All right, so the foot is divided into the tarsal bones, the metatarsals, and the phalanges. And the good news is that these bones are very similar in the arrangement as the bones of the hands. Okay, but now it's not the carpals and metacarpals, are the tarsals and metatarsals. And there are several metatarsals. I only want you guys to know two of them. The talus, which will articulate with the malleolus of the tibia and the fibula to form the knee joint, which is covered in articular cartilage, and the calcaneus, which is what we call our heel bone, which is the strongest bone in our foot, which is going to take a lot of the weight of our body. The metatarsals are the bones of the sole of our feet. And they are also numbered, just like the metacarpals, number 1 all the way through number 5. And then the phalanges follow exactly the same structure as the phalanges of the hand. So we have the number 1, which is the big toe, all the way through number 5, and they're also divided into smaller bones. The big toe only has a proximal and distal, but the other four has a proximal, middle, and distal bone. Okay, and they are named exactly the same way as the phalanges of the hands. Any questions, folks? All right, guys. Now again, what is the largest and the strongest of the tarsal bones? That would be the calcaneus. And since we're talking about the foot, let's talk about a condition which is quite common. I know several people that have that. This is what we call the flat feet. What is the flat feet condition, guys? This is when ligaments that holds on to the different bones on the sole of our feet, the metatarsals and also the tarsals, those ligaments are more stretchy. They don't hold the curvature at the bottom of our foot, at the sole of our foot. So when you step, you're not going to have the same spring in your step because those ligaments, they are more loose. And that can cause severe pain on your feet. Because when you don't have the same tension of the ligaments, the nerves that are running through the metatarsal, the sole of our feet, they are going to be compressed. And then when the nerves are compressed, they cause pain. Okay? All right, folks, the last thing I want to talk about for this chapter, I want to discuss about joint classification. Because not all joints are created the same. We have several different types and different functions of joints. We can classify joints as either structural, so there's the structural classification of joints, and we also have what is called the functional classification of joints. And there is a correlation between structural and functional classification. For the structural classification of joints, joints can be classified as fibrous, cartilaginous, or synovial. And I'm showing you here a circle, some example of each one of them. For example, we have a fibrous joint, which is the joint in between the cranium plates. Those joints, guys, are completely immovable. We cannot move the two plates of bones in our cranium because of this fibrous joint is also what we call a synarthrosis joint. So synarthrosis is a functional classification of the fibrous joints. And it's called synarthrosis because they are immovable. They don't move. Cartilaginous joints, like the joints in that holds our clavicle to the sternum, like the joints in between our vertebra, like the pubic symphysis joint, they are slightly movable, and we call those joints amphiarthrosis. So cartilaginous joints are also amphiarthrosis joints. And finally, the synovial joints, like the joints of our shoulder, like the joints of our elbow, like the joints of our hands and our knees and our ankle, they are what we call diarthrosis. And they are called diarthrosis because they are freely movable. Okay? So again, fibrous joints are synarthrosis. Cartilaginous joints are amphiarthrosis, and synovial joints are diarthrosis, freely movable. Now let's take a closer look at the synovial joint. And we have talked a little bit about synovial joint before because we talked about a membrane called synovial membrane. Everybody look up here, please. So what we're going to do, we're going to take a cut through our knuckle here, okay, the joint between our phalanges. And what we can see here in the red, we have this red membrane. This is the synovial membrane. And the synovial membrane will completely encapsulate the joint. It will encapsulate it, will close the joint. Now, the synovial membrane and the synovial cells, they produce a fluid called synovial fluid. What is the function of the synovial fluid, guys? Synovial fluid helps to lubricate our synovial joints. We only find the synovial fluid in synovial joints, okay? Because they are made by the cells in the synovial membrane. I have been looking for the past 8 years since I've been teaching this class. I've been looking for the unicorn, a double jointed person that can do this with their fingers. Anybody here in class can do that. Don't break your finger trying. Anybody here double jointed? And I'm not talking about from the front, right? I'm talking about the back. Oh my God, mine is so far out. No double jointed person? Still not going to be the semester. Maybe my afternoon class, I'm going to find one. But what is a double jointed? It's a little bit of a misnomer. Double jointed doesn't mean two joints. It simply means that that individual has a more loose ligament that allows for the ligaments to stretch further than most of us mere mortals. Okay. Now, among the synovial joints, there are several different types. Not all synovial joints are the same. We have what we call the plane joints, like the joints that we see in our wrist, in between the wrist bones. We have what is called the hinge joint and the pivot joint, which is a joint that we find in our elbow that allow us to move our forearm in different ways. We have the condylar joint, which is the joint between our metacarpals and the phalanges. And we have a saddle joint, which is a special joint that we find in our thumb, okay, right here. And finally, we have the most movable joint among the synovial, and that's what we call the ball and socket joint, which is an example of our shoulder joint is ball and socket, which is an example of our hip joint also is a ball and socket. Any questions, guys? Now, what happens as we get older? I know I should change this. I always end the chapters on a depressing note. But hey, we're all going to get old. Unfortunately, it's going to happen to all of us. But what's going to happen when we get older is that our articular cartilage is going to become thinner. And that is natural, okay? Because we have our chondrocytes start to die out. Chondrocytes are the cells that makes cartilage. Also, we're going to have a decreased production of synovial joints in our joints. You know, if you see an older folk, I'm already there. When you get up from bed or you get up from sitting down for a while, everything is cracking, right? Everything hurts. That is because we don't have enough fluid inside the synovial joint. And that fluid is very important to allow for lubrication of the joint. Okay? And our ligaments also is going to shorten and they're going to lose elasticity. And this is why it becomes harder to move as we get older. What can you do to help slow down this process? Exercise, folks. Physical activity is extremely important to keep your ligaments loose, to keep your ligaments from becoming short too fast, to increase the production of synovial fluid in your synovial joints. Now, very quickly here, let's talk about two procedures that are very common. In fact, my mother, when she was still alive, she had what is called a total knee replacement. And I am probably walking in that direction. I have arthritic knees, which is a present, a gift from my mother, a genetic gift from my mother. And she actually came to Hawaii to do that procedure. She was living in Brazil, came here to do that procedure. Now, what we're looking at right here, this is a artificial hip joint. A hip replacement is also very common. And then here we have a knee joint. And we can see right here on the left-hand side that this is extremely arthritic knee. You can see here that the cartilage, guys, the articular cartilage on the condyles is gone. Can you imagine how painful it is to walk when you have no articular cartilage in your joints? Every time you walk is bone grinding against bone. So at this point here, there's nothing to be done but to replace this joint with an artificial knee right there. So you're literally going to have to cut through the joint and then attach this metallic joint right here. Not a fun thing to do. And here we are looking at another condition called rheumatoid arthritis. This is an autoimmune disorder. What does autoimmune mean, guys? It means that our own immune cells are attacking the cells and the tissues of our body. And in this condition, we're going to have the attacking of the cartilage of our joints. The immune cells look at the cartilage and they see them as being foreigner, and they start to attack and destroy them. What's going to happen then, folks? We're going to have inflammation of the joint. We're going to have swelling and pain at the joint. And eventually, when you don't have any cartilage anymore, the bones will start fusing together. Because this is what happens when you have a bone against bone and touching directly. Our body thinks that there was a fracture and that we need to repair the fracture. So what's going to happen then, when bone touches bone directly without a cartilage, they will start fusing. And we can see right here in this X-ray, this knuckles here of this individual is already completely fused. Because again, there isn't any joint in there, any cartilage in there. Eventually, all of those joints are going to fuse together. All right, folks, this is all that I have for you today. Any questions? Anything at all? All right, so we are done with another chapter. And again, what I mentioned at the beginning of class, the quiz for chapter 5 is open right now. Okay, go ahead and take the quiz so you don't forget it and get it out of the way. Have a great weekend, folks, and I'll see all of you next week. Thank you.